Okay, good morning, everyone.
Good morning.
Thank you for being part of this episode of the YOF fortnightly webinar. We have actually taken a hiatus for a while, and we are glad to be back. And I also warmly welcome everyone to this discussion. The topic we'll be discussing today is peripheral ulcerative keratitis and Morin's ulcer, a condition that is really pertinent to clinical practice. And we have with us today a senior registrar from the Department of Ophthalmology, Ahmadu Bello University Teaching Hospital, Dr. Ndanusa, Majin Ndanusa. He will be giving us all the cerebral stuff about this topic today, as I know we've all been starved in the past 2 months or so. So please welcome him. Dr. Ndanusa, you have the floor, please.
Good morning, senior colleagues. Good morning, respected colleagues. I would like to thank the organizers for the opportunity given to me to present, to give a talk on peripheral ulcerative keratitis and Morin's ulcer. I am Dr. Ndanusa Majin, a resident in the Department of Ophthalmology, Ahmadu Bello University, Zaria. I'll be taking us through peripheral ulcerative keratitis and Morin's ulcer. I'll be using the following outline in the course of my presentation, which includes introduction, the anatomy, etiology, pathophysiology of PUK, presentation, differentials, management, and a few talk on the Morin's ulcer, and I'll conclude from there. As a way of introduction and definition, peripheral ulcerative keratitis, they are a group of potentially sight-threatening disruptive inflammatory diseases involving the peripheral cornea with characteristics crescent-shaped cornea ulceration, stroma thinning, and infiltration, often with an associated conjunctival and scleral inflammation. Just as the name implies, it's an ulceration that involves the peripheral cornea. So it takes the crescent shape of the cornea. It takes the shape of the crescent shape of the cornea, and it's characterized by progressive stromal thinning. It begins with a crescent disruptive inflammation at the cornea periphery, and is associated with epithelial defect, stromal inflammation, stromal inflammatory cells, which lead to progressive stromal melting, degradation, necrosis, and eventual perforation of the cornea. There may be associated inflammation of the adjacent tissues like the sclera in the form of necrotizing scleritis, or the episclera in the form of scleritis, and they may also have inflammation of the uveal tissue in the form of iridocyclitis. Mostly, PUK is associated with systemic autoimmune disorder, and it is found that nearly 50% of PUK is associated with collagen vascular diseases. And ocular manifestation may be the initial presentation of the systemic disease, or may be a presenting feature of a previously undiagnosed systemic collagen vascular disorder. So our role as ophthalmology, when we see this patient, we want to investigate this patient for this systemic disease, because sometimes we may be the first presentation may be ocular manifestation. So the anatomy. Now, what constitutes the peripheral cornea? Since we said it's the ulceration of the peripheral cornea, we need to define what constitutes the peripheral cornea. Now, there is no clear-cut borders delineating the peripheral cornea. However, it is said that the portion located between the central 50% of the cornea from the image here, this region constitute the 50%, the central 50% of the cornea. The portion between that central 50% and the limbus is what is considered to be the peripheral cornea. So we can see there is this, let me see if I can bring out my, this area is the central 50% of the cornea. Then the outer part here, which is the inner portion of the limbus. So that portion in between that 50% and the inner portion of the limbus constitutes the peripheral cornea. And it is said that an habitual central limit beginning at 3.5 to 4.5 millimeter from the visual axis, extending to the junction of ill-defined transition between the limbus and the conjunctiva. So this is the area that constitute the peripheral cornea. And also that directly adjacent to the limbus is the internal angle structure. The reason why we're bringing the issue of internal angle structure is to see later in the course of the presentation that they may also present with glaucoma from the inflammatory cells around the angled structure. And that highly vascular zone with associated lymphatic tissue, scleral collagen, corneal collagen, and limbal stem cells. That is, this is the anatomy of the limbus. It is highly vascular with associated lymphatic tissue, scleral collagen, and corneal collagen, and also limbal stem cells. Now, why is the peripheral cornea involved first in PUK? The reason is what I'm about to present here. That the thick, as we all know from our basic, that the peripheral cornea is the thickest, the peripheral cornea has the thickest is the thickest of all the cornea compared to the central cornea, that is which is the thinnest, and it accounts for about the thickness accounts for about 0.7 millimeter with tight collagen bundle pattern, and a vascular arcade originating from the anterior ciliary artery extends approximately 0.5 millimeter into the cornea. So these anterior ciliary arteries are actually from the conjunctiva through the limbus into the peripheral cornea. Now, unlike the central cornea that is avascular, the peripheral cornea derives its blood supply from the anterior conjunctiva and deep scleral vessels. This explains why the peripheral cornea is involved, because we will later get to know that the antibodies that are coming from the system get access to the peripheral cornea first through this vessel. So as you can see from the image projected, you can see this portion here, this region, this is the avascular arcade that extends into the peripheral cornea, and that it extends about 0.5 millimeter into the clear cornea. It provides nutrition and also access to the immune system. Then the other reason is because the peripheral cornea has some unique immunological characteristics, such as prevalence of Langerhans cells at around the peripheral cornea. There's also relative higher concentration of IgM at the peripheral cornea. Also, the peripheral cornea has a higher concentration of the first complement, that is C1. So all this reason explains why the peripheral cornea is involved in peripheral ulcerative keratitis. Now, the etiology, basically, PUK is divided into the etiologies are divided into infectious and non-infectious broadly. Then both the infectious is subdivided into two. We have the ocular etiology and the systemic etiology. The ocular etiology includes the bacteria, the viral, and the fungal. Now, the viral, bacteria, and the fungal do not directly cause the ulceration that is seen at the peripheral. Rather, it's either hypersensitivity to this bacteria, viral or fungal that results to the peripheral ulcerative keratitis that is seen in this case. And also systemic diseases such as tuberculosis, syphilis, and gonorrhea through the same process will result in peripheral ulcerative keratitis, PUK. Now, the non-infectious etiologies are also divided into two, the ocular and the systemic. Now, the ocular entails Morin's ulcer, marginal keratitis, ocular rosacea. Now, the point to note here is that Morin's ulcer, some authors decide to differentiate, classify them on a different, not like they don't, the Morin's ulcer is not classified under PUK. For some authors, some other people decide, some authors decide to, since it involves the peripheral cornea, they tend to lump it up in the ocular cause of the PUK. Now, the systemic causes of peripheral ulcerative keratitis include the rheumatoid arthritis, vaginal granulomatosis, known as the granulomatosis with polyangiitis. We also have the inflammatory bowel disease. In the recent PUK is described in association with systemic autoimmune diseases. So most of the time, once we talk about PUK, it is actually referring to peripheral ulcerative keratitis that is associated to this systemic illness and systemic condition, autoimmune condition. Hello?
Hello,
Yeah, we
Dr.
are
Ndanusa,
together.
we're with you. Go ahead.
Yes, we are with you. Thank you. I want to be sure that we are together. Now, there is the concerning the epidemiology, because of the controversies as to which ocular conditions to be categorized as peripheral ulcerative keratitis. So there is no specific epidemiology associated with it. However, what is agreed on is that there is an equal prevalence of male and female and PUK, just as we have said earlier, that has been associated with many autoimmune disorders, such as the collagen vascular diseases. And among the collagen vascular diseases, rheumatoid arthritis accounts for about 34 to 42% of PUK patients. The other collagen vascular disease that could be seen in association with PUK, with the systemic lupus erythematosus, relapsing polychondritis, and progressive systemic fibrosis. Then we also have some other autoimmune diseases, systemic autoimmune diseases, such as polyarthritis nodosa, inflammatory bowel disease, and anchor vasculitis are also among the systemic autoimmune disease that may present with peripheral ulcerative keratitis. And a point to note here is that the anchor vasculitis are associated with high mortality, and that is why the prompt diagnosis is vital, is essential to prevent mortality from this illness. Just as I mentioned earlier in the introduction, that sometimes ocular manifestation is the first, it's actually the first presentation of this condition. So if as an ophthalmology we can pick this condition early, or when we see them, we refer them to the rheumatologist or an immunologist where present, so as to evaluate the patient and see if they have any of these fecal anchor vasculitis. Now, coming to the pathogenesis, the exact pathophysiologic mechanism is unclear. However, the proposed mechanism in immunological pathogenesis include that circulating immune complex deposition at the peripheral cornea and autoimmune reaction to the corneal antigen from this complex deposition, Well, it will also be due to associated hypersensitivity reaction to exogenous antigens. And also, evidence suggests that both humoral and cell-mediated mechanisms, that is the T and the B cells, are involved in the pathogenesis of peripheral ulcerative keratitis. This is just a picture showing the pathogenesis. That from various etiologies, we have inflammatory reaction at the peripheral cornea coming from the anterior ciliary arteries to the peripheral cornea. Immune deposition and complement activation, of course. Then we have immune vasculitis, that is the damage to this vascular wall at the peripheral cornea. Further increase in vascular permeability causing leakage, then generates chemotactic factors for neutrophil pro-inflammatory cytokines, as the C3A and the C5A. Then the neutrophil is recruited at the peripheral cornea, liberates proteolytic and collagenetic enzymes alongside with the metalloproteinases. These enzymes that are released are what eventually result in the destruction of the cornea stroma, resulting in progressive cornea thinning. Now, the presentation, the ocular presentation, basically, the presenting symptoms of PUK are not specific. It may be unilateral initially, then later becomes bilateral. The non-specific symptoms the patient usually presents with is foreign body sensation, watery, pain, and photophobia. The pain is severe when it is associated with scleritis, and pain with without sclera involvement to raise high suspicion of Morin's ulcer. Now, patients may also present with decreased vision because of the induced astigmatism from the peripheral corneal ulceration. Patients may also present with phobia. Just as I said earlier, ocular manifestation may be the initial presentation of the aforementioned systemic diseases. So, as ophthalmologists, once we see a patient with this condition, we will invite the rheumatologist to review. And patient may also present with issue of the issue of the autoimmune disorder for those that have established systemic disease. Now, how do we assess this patient clinically? Assessment, we look at the laterality, whether it's unilateral or bilateral. Most cases start for PUK, they are mostly bilateral and may start at unilateral initially, then later involves the second eye. Then we also have to assess the extent of the peripheral cornea that is involved, and the extent is stated in terms of clock hours. Then we also have to we assess the thinning, how thin the cornea is. Then also epithelial defects using fluorescein dye. Now, just as I said, it may be unilateral or bilateral. The classical picture of PUK is this presenting perilimbar corneal ulcer. Just as you've seen in the picture, the two arrows is showing the area of the peripheral ulcer with soft epithelial infiltrate at the edge of the ulcer. That is at the edge of the ulcer, that is the edge that is towards the pupil, not the limbus. Now, with PUK, there is progressive spread and thinning of the ulcer. The thinning because of the effect of those proteolytic or the collagenase enzyme eating up the corneal stroma, and that the amount of stromal loss is underappreciated due to the depth. Hello?
You're back now.
Okay. The amount of the stromal loss is usually underappreciated due to the debris and necrotic material deposited at the base of the ulcer. So clinically, it is when assessing this patient, it is expected that we do cornea stripping to reveal the real depth of the stroma lost, and also, as I said in the introduction, we will also have involvement of contiguous tissues like the sclera in the form of conjunctivitis, episclera, and sclera in the form of scleritis, and the occasional anterior chamber reaction from iridocyclitis. And now the ulceration can progress rapidly, leading to corneal perforation and its complication. There can be superimposed bacterial conjunctivitis and keratitis, which patient may present with such patient may present with eye discharge, or may present with hypothium. Hypothium is not a typical presentation of PUK. Whenever you see hypothium in the patient with PUK, we should suspect superimposed bacterial keratitis. Now, when PUK is associated with scleritis, there exists a worse ocular and systemic outcome than when it is scleritis alone. The complications that may result from PUK include severe astigmatism, secondary bacterial infections because there's epithelial defect and ulceration. The end point of this stroma thinning is perforation, and patients with PUK may eventually present with cataract. The cataract may be due to cataract and glaucoma are complications of PUK, which may be as a result of the inflammatory process. For cataract, it may be due to the iridocyclitis, and then the medications, because most of these patients will be on the steroid, which may also account for the cataract that the patient may present with. The same reason applies to glaucoma. These patients may present with glaucoma as a primary disease process or secondary to the use of steroids. Now, looking at the systemic association, as I said earlier, that about 50% of PUP have collagen vascular disease, and rheumatoid arthritis is the most common of the systemic association of PUP. Vaginal granulomatosis and other ANCA-associated vasculitis, although they are rare, they have high mortality. And it is it's essential that when we are seeing patients with PUK, to have a cross consultation with rheumatologist or immunologist. Now, the diagnostic workup for patients that are suspected to have PUK entails a thorough ocular history of contact lens use, current and previous medication of any disease, trauma, or surgery. Then a comprehensive systemic review to rule out systemic diseases associated with the PUK. A complete ophthalmic examination to rule out local pathologies is critical. Now, the investigations for peripheral ulcerative keratitis, there are a number of investigations that can be done for patients with PUK. This investigation basically is to establish the presence of systemic autoimmune disease. Or sometimes the investigations are done like the complete blood count is done to have a baseline hemogram before instituting medication. For treatment, ESR and C-reactive proteins can be requested for. It also helps in monitoring the progress of the treatment in some of the systemic illness. Rheumatoid factor is positive in 80% of patients with rheumatoid arthritis, and the anti-CCP It's also one of the tests that can be done for patients with rheumatoid arthritis. It is said that anti-CCP is more specific than the rheumatoid factor. Angiotensin converting enzyme for a positive for patients with sarcoidosis. We have anti-nuclear antibodies, that is ANA, for SLE and rheumatoid arthritis. Antibody to double-stranded DNA for SLE. There are antibodies to small fragment ribonucleoprotein, that is anti-RNA for SLE. So consider there are a number of investigations here. The investigations are tailored to the clinicians, what the clinician is suspecting. If for most patients that present with PUK should have some of these investigations done, because they may not have an obvious presentation as to this systemic illness, but this investigation may unravel the systemic illness before its manifestation. You can also do request for retroviral screening. Retroviral screening is done because this patient will eventually be on the immunosuppressive agent. And we also need to know the glycemic status of the patient. For the same reason, the patient should be on immunosuppressive agent, and also corticosteroid has the side effect of causing hyperglycemia. So we need to know the baseline glycemic level before commencing this patient on this steroid. Now, biopsy of the bulbar conjunctiva adjacent to the ulcerating cornea should be considered, especially in suspected autoimmune associated PUK or in malignancy. So the point here is that sometimes we shouldn't forget that malignancy could also malignancy in the form of OSSN could also present with ulceration of the peripheral cornea. So when taking tissues for conjunctival resection, these tissues should be sent for histo to pathology for histo analysis. Management principle basically is to minimize inflammation, prevent bacterial super infection, promote healing of the ulcer, and to modulate systemic inflammatory response to prevent possible recurrence as well as minimize complications. Now, the management is basically divided into two: the medical management and surgical management. It can also be divided into local and systemic management. But for our presentation, we will divide it into medical and surgical management. We usually start with topical steroid. The steroid is the initial therapy in milder unilateral cases, typically when not associated with systemic connective tissue disorder. It's also useful in mild cases of rheumatoid-associated PUK. However, it is harmful in subsets of vasculitis PUK because they inhibit, as you all know, steroid inhibits collagen production, thereby worsening the collagen breakdown that's seen in some of the conditions. And in this case, we rather use, it's advisable to use topical cycloserine. The only downside to cycloserine is the onset of action. It's not as rapid as that of topical steroid. And in our environment here, availability is also a problem. We can also use topical ointment and tacrolimus. However, the availability is a problem in our environment. Then systemic corticosteroid in the form of oral prednisolone, 1 milligram per kg per day, is used in severe cases of peripheral ulcerative keratitis. And if there is progression, then we can introduce the intravenous methyl prednisolone, 1 gram, 0.5 to 1 gram daily for 3 days, then commence on the oral steroid. The point to note here is that patients on steroids should, for every visit, should have their IOP checked for those that have steroid responders, the pressures may be elevated that will require the need of the use of anti-glaucoma medication. Now, what are the indications for immunosuppressive agents? Include PUK associated with potentially lethal systemic disease such as vaginal granulomatosis, relapsing polychondritis, polyarthritis, Ndanusa. Or when we have PUK with associated scleritis, patients with bilateral Morin's ulcer, then disease progression despite local conjunctival resection and tectonic procedure. These are the indications for immunosuppressive agents. Now, the immunomodulative agents that can be used are the antimetabolites. The commonly ones are used is the methotrexate and azathioprine. We can also use alkylating agents such as cyclophosphamide. The other ones are not readily available. However, the T-cell inhibitors can come in the form of topical medication, as in the cycloserine and the tacrolimus. Now, the point to note here is that most of these immunomodulatory agents are being administered by the rheumatologist. They are experts in administering this immunomodulatory agent, and that is why PUK should not be managed in isolation. Rheumatologist consultation is required. So it's expected that the patient is co-managed with the rheumatologist, because they are able to administer this medication and also monitor the side effects of these medications. Now, prophylactic antibiotics for patients with on topical immunosuppressive agents like steroids will also be on antibiotics for prophylaxis. And patients with suspected bacterial superinfection should have antimicrobial therapy. Then scraping of the debris and necrotic material at the base of the ulcer enhance penetration of the ocular medication. So before one commences ocular medication for patients with PUK, it is advisable to scrape the debris. This enhanced penetration, and also it also gives the clinician the idea of the depth of the corneal ulceration. Now, the surgical management basically is to maintain the integrity of the globe and also to prevent the autoimmune antibodies from getting to the cornea. So among which is the conjunctival resection. Conjunctival resection is based on the assumption that the antibodies are coming from the conjunctival blood vessels to the peripheral cornea. So it is believed that removal of this of the conjunctiva will limit the access of these autoantibodies to the peripheral cornea, and this conjunctival resection may be of great diagnostic help, since this the tissue that is taken, the conjunctiva that is taken, is sent to ideally should be sent to histology for analysis. Now, there is a way that the conjunctival resection is done. It is done. The conjunctiva is set about 4 millimeters away from the limbus, and 2 clock hour or 2 millimeters from the margin of the lesion. I will explain that better when I get to Maureen's ulcer. Now, we also do it's also advisable to field the defects. The defects with acrylate glue. The acrylate glue has two dual benefits. One of which is that it strengthens with filled, once the ulceration is filled with the acrylate glue, it serves as a barrier for the inflammatory cells from the conjunctival vessels to get as a barrier between the host cornea and the epithelializing conjunctiva and also the immune component. The other thing is that it also strengthens the cornea, thereby preventing perforation. So the pattern that is done is to do a conjunctival resection. We put glue in the defect, that is the cornea, area of the cornea that is ulcerated. Then we put a bandage contact lens. Then point to note here is that in the follow-up, sometimes this glue can become loose. When the glue loosens up, it can be replaced depending on the depth of the corneal ulceration at the time the patient is being at the time the patient is followed up. Now, for a cornea patch as a surgical modality is done when when the perforation is large for tissue adhesive to seal. Some type of patch may be necessary. This may range from a small tapered plug of the cornea tissue to penetrating keratoplasty. Penetrating keratoplasty is usually the end of it's usually the end point when we have corneal opacity after the condition has healed. So it's like a rehabilitative procedure. Now this is just a picture showing the middle image here shows the perforation of the cornea. Then the image by the right is showing the patch graft at the peripheral of the cornea. Now this patch graft, some people call it banana graft because it has the shape of the banana, and the aim of this is to seal the perforation. And just I forgot to mention that the glue too can be used for when we have micro or perforation less than 2 millimeter. So we can also do superficial lamellar keratectomy. The idea is to take out the superficial stroma where these inflammatory cells are in order to arrest the process and allow healing. And as I've mentioned earlier, then you have rehabilitative surgical therapy in the form of penetrating keratoplasty. Now, conjunctival flap. Well, although most authors don't recommend conjunctival flap, however, because getting some centers don't have access to the cornea patch and all of that. So, the argument put forward by those that do conjunctival flap in the form of Goodwinson flap is that instead of allowing the cornea to perforate when there is an obvious thinning of the cornea, why not just get a conjunctival flap and cover the area, thereby preventing cornea perforation? But it's advisable to avoid conjunctival flap because just as we have said, most of the inflammatory cell is coming from the conjunctival vessels. So conjunctival flap is usually more beneficial for patients with Warren's ulcer than those with PUK. Now, the differential diagnosis of PUK include Warren's ulcer, which I will discuss briefly after the talk. Then we have Terence marginal degeneration. Terence marginal degeneration also presents with degeneration. The key presentation here is that there is degeneration of the peripheral cornea. However, there is no ulceration. Then pelvic marginal degeneration is also a differential of PUK. However, it's a non-inflammatory corneal aesthesia which involve cornea thinning without perforation. The others include senile furrow degeneration, exposure keratitis, then OSSN. Now, I will just give a brief talk on Morin's ulcer. Morin's ulcer is a rare autoimmune disease characterized by progressive circumferential peripheral corneal ulceration with later central spread. It's an idiopathic inflammatory ulcerative keratitis. It is also known as the serpiginous corneal ulcer because of the characteristics of the ulcer. Now, the risk factors, the etiology basically of Morin's ulcer is not known. However, there are some immunological components to it. HLA DR17 and HLA D22 have been associated with Morin's ulcer, and environmental uh, causes such as trauma, surgery, and infection have also been associated as a risk factor for Morin's ulcer. Hepatitis C has also been associated with the occurrence of Morin's ulcer and helminthic infestation in the form of typhus. I think a number of research was done in Nigeria here that associated hookworm infestation to Morin's ulcer. The other part of it is that it has been found that even areas where this hookworm infestation is endemic doesn't they don't tend to have more cases of Morin's ulcer. However, it has been said that hookworm infestation is associated with Morin's ulcer. Epidemiology of Morin's ulcer. The Morin's ulcer is a real disease. It's more common in the southern hemisphere, including southern and central Africa and India, suggesting genetic and geographic predisposition. Generally, more common in men, however, figure differs from one geographic population to the next in time of age distribution. Epidemiologic picture may differ in African population, as suggested by a study in Nigeria where the disease mostly affects men in their 20s. Generally, two age groups commonly affected, the young and the elderly. The pathophysiology, it is just as I mentioned earlier, it is mainly idiopathic. So the exact etiology is unknown. However, it has been postulated that Morin's ulcer may result from autoimmune etiology, from sensitization of calgranulin C, an antigen expressed on corneal stroma keratocyte, following trauma keratitis, causing unveiling of this hidden corneal antigen. That is why most patients that present with corneal ulcer usually give issue of some either trauma or foreign body in the eye. And hidden antigen may unveil naturally in some predisposed people with Morin's ulcer with age. Now, this exposed corneal antigen then triggers an immune response in which complements are activated, neutrophils degranulate and release collagenase. This collagenase what destroys the corneal stroma, thereby resulting in the ulceration that is seen. The ulceration begins at the tricenteric corneal peripheral, progresses towards the center of the cornea, leaving behind intact epithelium and the endothelium. I think the point here is that in Morin's ulcer, the endothelium is usually intact and the epithelium of the cornea, resulting in what is called the overhanging edge. What they mean by the overhanging edge is that if you look at the image here, you can see there's a depression from the slit light. Now, between the cornea end the between the edge of the ulcer, the cornea end, and that of the lumbar edge. Now, it is for the overhanging. I don't know how to really explain it, but what they mean by overhanging here is that one can pass its probe in between the cornea end of this ulcer down. I really don't. I try to see if I can get a diagram to show, but let me see if I can draw out. If I can draw it with a pen as to what is meant by overhanging. The overhanging is in this form, this way. I don't know if you are seeing the screen. Now, this part here is what is the cornea end of the ulcer. Now, as you can see from the image, from what I drew on the screen here, you can see that it's overhanging. So this is characteristics of Morris ulcer, but not pathognomonic. So eventually, the entire cornea will be consumed, and with progression of the stromal thinning, perforation will result. Now, there are three zones of cornea involvement in Morris ulcer. We have the superficial stroma, which contains the plasma cell, lymphocyte, neutrophil, vascular element. The mid-stroma, in the mid-stroma, there is increased number of fibroblasts, and the deep stroma is infiltrated primarily by macrophages, and that the descendant membrane is unaffected. So in Morris ulcer, both the descendant membrane, the endothelium are unaffected. Then conjunctival resection shows mononuclear infiltrate as the plasma cell, histiocyte, and the eosinophil. And Morris ulcer usually do not have associated Keratitis, we are seen in PUK. Now there are two clinical type of Morris ulcer, the type 1 and the type 2. Type 1 is usually unilateral, mild to moderate, has mild to moderate symptoms. Generally, they respond well to medication and surgical treatment, tend to occur in older patients, and they are known as typical or benign Morris ulcer. The second type, the type 2, is usually bilateral, have more severe symptoms than the type 1, and the response to treatment is poor. It occurs more in younger patients. It is known as atypical or malignant Morris ulcer. Now, the clinical features is similar to that of peripheral ulcerative keratitis. The symptoms are non-specific. They usually present with pain, redness, foreign body sensation, tearing, photophobia, and blurring of vision. Now, from the characteristics of the ulcer of Morris ulcer is that one is that it occurs at the limbus, and that is why its time as peripheral uh, its time among the peripheral ulcerative keratitis, and it has an crescent infiltrate at the limbus with an epithelial defect. The stroma melts and the overhanging edge that I explained earlier in the pathogenesis. So these are the basic characteristics of corneal ulcer, of Morris ulcer rather. Now the signs, the peripheral ulceration involves the superficial one-third of the stroma with variable epithelial loss. Several distinct foci may be present and may coalesce. An undermined and infiltrated leading edge is characteristic of this ulcer. Limbitis might be present but not scleritis. This helps to differentiate it from systemic disease-associated PUK. Then with time, there's progressive circumferential and there's central stroma thinning, vascularization involving the bed of the ulcer up to its leading edge, but not beyond. Then the healing stage is characterized by thinning, vascularization, and scarring. Iritis is not common in the Morris ulcer. Now, there is this criteria for the diagnosis of Morris ulcer. It's called the Watson's criteria, and it includes crescent-shaped peripheral corneal disease, extensive undermining of the cornea edge of the ulcer, corneal infiltration along the leading edge, absence of scleritis, and absence of detectable systemic illness. So this is the cause of Morris ulcer. It usually starts as an infiltrate at around the peripheral cornea. You can see the image on the right side as an infiltrate. Then later becomes ulcerated. With time, it progresses over the period of 2 weeks to infiltrate and epithelial defect progression at the edge of the ulcer. Then eventually the patient may present with perforation of the ulcer, which is seen looking at the image on the right side. You can see the perforation of the ulcer with iris solar. Now the investigation is the same with PUK. We do because diagnosis of Morris ulcer it's a diagnosis of exclusion when every other cause of peripheral ulcerative keratitis have been excluded. Then we make the diagnosis of of Morris ulcer. So the investigations are the same with that of peripheral ulcerative keratitis. And just as I said, Morris ulcer is a diagnosis of exclusion. Now the treatment, just like PUK, we start with topical steroids. When the patient is not tolerant to topical steroid, we can use topical cycloserine 15%. Tacrolimus ointment can also be used in refractory cases. However, this tacrolimus is not readily available in our environment. Then adjuvant topical therapy include artificial tears and collagenase inhibitors such as acetal-cysteine, 10 to 20%. Immunosuppressive suppression may be needed, including steroid for rapid effect, and should be instituted earlier in the case of bilateral disease and if there is involvement, if bilateral disease or if involved in advance at first examination. Then, just as you know, because the progressive stroma thinning is due to the collagenase activity, it is suggested that doxycycline may be beneficial because it inhibits collagenase. Now there is this step ladder evaluation approach to the management to the immunosuppressive use in Morris ulcer. This study was done by Jatin N and al. That for patient with unilateral Morris ulcer with less than 2 quadrants of peripheral corneal involvement and less than 50% stromal loss, topical steroid will suffice. Whereas for those with bilateral cases, more than 2 quadrants of peripheral corneal involvement and more than 50% stromal loss, oral steroid should be used. For patients with steroid intolerance or younger patients less than 40 years with bilateral disease, or patient with just one eye, that is single eye, oral methotrexate should be used. Then for those with bilateral single eye, more than 3 quadrants peripheral corneal involvement, and more than 50% stromal loss with an impending perforation, intravenous methylprednisolone can be instituted in this patient. Then for those that have bilateral condition, or those that have single eye with more than 3 quadrants of the peripheral cornea involvement, perforation, or in early postoperative period after keratoplasty, this patient should be placed on the IVMP, intravenous methylprednisolone, and IV intravenous cyclophosphamide So this is a stepladder approach that was proposed by by Jackson and Eto for the management of Morin's ulcer. Now, the surgical management is the same as that of peripheral ulcerative keratitis. It involves conjunctival resection, and I explained that the area that should be excised of the conjunctiva should extend 4 millimeter back from the limbus and 2 millimeter or 2 clock hour beyond the circumferential margin. The in the in the next slide here, you can see the two pictures here. The first one is the patient with the Morin's ulcer. Now, the resection that is done, you can appreciate that it was extended beyond about 4 millimeter beyond the corneal limbus. That is from here. Let me see if I can bring out my marker. It's not coming up. Then from the edge of the ulcer, 4 millimeter beyond the edge of the ulcer, and 2 millimeter at the uh, at the end of the 2 millimeters or 2 clock hours beyond the lesion. I don't know. I wish I could project this is also explain it better. Okay. At this point here, 2 millimeter beyond the 2 millimeter or 2 clock hours beyond this the ulcer edge, then 4 millimeter beyond the ulcer limit on the cornea. That is how the section is done. And the rationale behind it is to prevent the autoimmune antibodies from getting to the peripheral cornea. Then the use of glue, it actually serves two purposes. It strengthens the cornea and also serves as a barrier. So the same way as we do in PUK, we resect the conjunctiva, apply the glue at the ulcer, then we cover with bandage contact lens. Then the other surgery is the same as the peripheral ulcerative keratitis, as in for perforation, for large perforation, we do a patch graft. Then once we have all the cornea involved, you can do penetrating keratoplasty when the inflammatory process have subsided. So in conclusion, immune-mediated peripheral ulcerative keratitis is rare but a grave disease. Although autoimmune PUK and Morin's ulcer exhibit overlapping clinical features, they represent distinct pathological entities, differing significantly in etiology, systemic association, and management approach. Immunosuppression is the mainstay of the medical therapy. Rheumatology and immunology consultation is essential in the evaluation of PUK. Surgical modalities include the conjunctival resection, the cyanoacrylate glue application, tenous or amniotic membrane corneal patch graft. Then as ophthalmology, we should always look beyond the eye when evaluating patients with peripheral ulceration. Thank you for your time. Thank you for listening.
Thank you so very much, Dr. Ndanusa, for that comprehensive presentation on peripheral ulcerative keratitis and Morin's ulcer. Thank you everyone for listening. Our time is fast spent. We're already at 10 o'clock, but crave your indulgence to take a few more minutes so that we can answer some questions. And during the session, while the presentation was ongoing, we had people post their questions in the chat box. Dr. Ndanusa, we have about 3 questions which we'll quickly run through, and then we'll take about 1 or 2 from the audience. The first question is, I wasn't quite clear on the relationship with peripheral ulcerative keratitis scleritis and Morin's ulcer. That's from Dr. Shafiat Lasisi. Would you want to take the questions one by one, Dr. Ndanusa, or should I run through all of them and then you take them?
I think I'll take it one by one.
Okay, all right.
Well, for peripheral ulcerative keratitis, they may have associated scleritis. Just as I mentioned in the presentation, they may have contiguous tissues involved, like the sclera. So they may have associated scleritis, episcleritis. Whereas in Morin's ulcer do not usually present with scleritis. Once there's scleritis, then our focus will be more of peripheral ulcerative keratitis. However, it has been said that some bilateral cases of scleritis might scleritis might be seen in bilateral Morin's ulcer, but it's not typical for Morin's ulcer to have scleritis.
All right, thank you. Dr. Uzoma Ugweke wants to know, please, can you explain more on how to rule out the presence of scleritis in an eye with peripheral ulcerative keratitis that is already diffused, injected, especially when we want to rule out the diagnosis of Morin's ulcer?
Okay. Well, for the fact that the sclera, the conjunctiva is inflamed or hyperemic and is diffuse, and there is no eye discharge, then we can suspect that it might be an episcleritis or a scleritis. Because for Morin's ulcer, basically the conjunctiva is quiet, except when we have bacterial superinfection. So once there is a conjunctiva hyperemia and there is ulceration, then our mind should go towards PUK rather than I know it may be except for scleritis and episcleritis, there is this test that we do, this Pinelefrin test now that may help to differentiate. But once a patient has peripheral ulceration with diffuse conjunctival hyperemia, I think whether there is scleritis or episcleritis, the treatment is still the same.
Correct.
I don't know if I've answered it enough, or if there's someone that has a better explanation.
Okay. All right.
Sorry, but what, Chief Ndanusa, sorry. What of the severity of the pain?
Yes, sorry. Yes, severity of the pain. Once there is severe pain, it tends towards scleritis.
All right. For the questioner, has that question been answered? If not, you can please indicate. Another question here is, please, in the classification of Morin's, which is commonly used, the type 1 and 2, or the bilateral advanced, bilateral indolent, unilateral Morin's classification? He wants to know which is commonly used.
I think
possibly
the
in the
one
treatment.
that I'm used to, or that I've seen in most books, is type 1, type 2. Type 1, type 2. Besides, the type 1, 2 is also called the benign. Then the type 2 is called the malignant. So I don't know if there is any difference, but the one that was from the book, the one that is commonly used is the type 1, type 2.
Correct.
But it's all the same. There's no difference whether you classify it as type 1, type 2, or indolent or benign. Indolent or benign or malignant, it's still, because the treatment is still the same.
All right. Just wanted to know which one is most commonly used. Is there a role for amniotic membrane grafts as an alternative to conjunctival tissue?
Yes, sorry, I forgot to mention in the course of yes, there's a role for amniotic membrane graft. Usually, instead of doing a conjunctival flap, if you are when amniotic membrane tissue graft if available can be used instead of the conjunctival flap.
And I
It's
believe that
really
will
for it.
reduce the chances of worsening that comes with conjunctival flap in
Yeah.
some cases.
Sometimes once you have bacterial super infection that is difficult to control, using an amniotic membrane to cover the defects with extensive antibiotics. So that's that is one of the benefits of using amniotic membrane graft.
All right, thank you. Another question here is it's a form of contribution that the pain in Morins is usually severe out of proportion to the clinical findings in a seemingly quiet eye. Here's a
Thank you.
contribution from Dr. Ann. Thank you very much, Dr. Ann. Someone has been raising their arm. Dr. Olanle Balogun, you have the floor, please.
Good morning, everyone. Thanks so much, Dr. Ndanusa. I'm not a resident, but I enjoy joining this youth group. I always try to do. So my contribution is we shouldn't forget the place of counseling with these patients because these ulcers, they have impact on patients' quality of life. And then patients' expectation should be managed as well. For those on steroids, IOP monitoring, blood pressure, blood sugar monitoring is very important in our follow-ups. And then I wanted to ask the histopathological findings when you resect the conjunctiva, what are we expecting? And does that help us to differentiate these different ulcers? And then is there room for social welfare care for these patients? Thank you very much.
You're welcome. Thank you for the contribution. I think the first question is on how do you
Counseling.
counseling. Yes, you
That
said
was
yes,
a,
yes.
it was
Yeah,
a
that was a
contribution.
contribution.
But it's very
Yeah,
important, please. You
yes,
didn't
it's very
mention it at
important. Yes,
all.
it's
Very,
very
very
important.
important. Yes. And to manage
Then,
patients' expectations as well.
yeah. Then the first question was
Histopathological findings
yes,
of the
histopathological findings.
conjunctiva.
Basically, it will show inflammatory cells, basically, which may not really be difficult for one to differentiate because the inflammatory cells that are seen in Morins are similar to those that are seen in PUK. So that alone is not enough to differentiate Morins from ulcer. The PUK from ulcer, Morins ulcer. The reason for the histopathology is saying that sometimes patient may have a malignancy that may not depict that one may be thinking is PUK. Then you treat and there may be no response. But when you send a sample to histology, it will tell if the condition that one is managing is malignancy.
Thank you
Then
very much.
you're welcome.
Thanks so much. Keep the flag flying, youth group. Thank
Thank you
you.
so very much, ma.
Thank you, sir.
Thank you, ma, for your contribution and your questions.
Thank
Do we
you.
have any more questions or any contributions? In the absence of any more contributions, we would like to round up this session of the Young Ophthalmologist Forum fortnightly webinar. And thank you very much for everyone for joining us. We hope to see you again in another 2 weeks. Dr. Ndanusa, we really appreciate your contribution. Thank you so very much. You have really enlightened us this morning on Maureen's ulcer as well as peripheral ulcerative keratitis. Thank you so very much, everyone.
Thank you, Chief Ndanusa. Thank you,
Thank
Chief
you.
Moderator.
Thank you so much.